Hey guys, this is Charity Stanley, and today we're talking about how to assess the respiratory system. Okay, so this is talking about basic respiratory system assessment skills and things that you need to know. So, one of the big things that we're talking about with looking at the respiratory system is gas exchange and making sure that the blood, as it's being oxygenated, is getting to the tissues where it needs to be. So, reminder of anatomy and physiology. So, we've got the upper airway, the lower airway, and then the alveolar air sacs, which is where the capillaries actually are exchanging the carbon dioxide to be removed from the body from breathing out and putting oxygen on the red blood cells. So this is gas exchange, and then we're looking at it being pumped through the rest of the body through perfusion. So our upper airway consists of our nose, our sinuses, our pharynx, and also our larynx. The lower airway consists of the trachea. This is the lungs part, two main stem bronchi. Now, the angles of the bronchi that come off of the trachea, the right bronchus has a less sharp curve. So you do have to watch if you have to do advanced airway skills. Frequently, the tube will end up in the right main stem bronchus instead of being able to make the almost right angle turn to be able to go into the left main stem bronchus. So if that happens, you just pull back on the tube and then you should be able to oxygenate as you need to. So with the respiratory system, changes happen with aging. As you age, you get exposed to more pollutants within the atmosphere and within the air. Also, depending on what kind of profession you have, you may have environmental exposure to paint or to pesticides. And as with everything, as you age, each system of the body stops working as effectively and as efficiently as it once did. So, with health maintenance and health promotion, big thing is to minimize exposure to inhalation irritants. Make sure people stop smoking or don't start smoking. When you are smoking, you're exposed to tar, nicotine, and increases of carbon monoxide. Now, recently, we're having a lot of people vaping, especially younger people are more attracted to the vaping. What we have found with vaping is that it actually increases the irritant exposure and is not healthier than smoking tobacco. So, passive smoking, secondhand and third hand smoke. When we are doing an assessment on a patient that's a smoker, we need to find out how many cigarettes they're smoking per day times the number of years. This is a measurement called a pack year. So the higher number of packs that a person smokes, the more damage that they're doing over a longer period of time. So there's several smoking cessation products. Some of them are uh, used through the skin, and you put a sticker on the skin and it helps to release nicotine in a time delayed manner to be able to help break the habit of smoking as you decrease the patient's exposure to nicotine. The 5 A's. The big thing that you need to know is to assess the desire to quit. When a patient is ready to quit, it is very important that you be able to provide the information within the community to be able to get them the resources they need to be able to quit. So there's several other over-the-counter drug therapies, nicotine replacement patches that we've talked about. We also can prescribe bupropion. Bupropion has been associated to decrease the nicotine cravings and decrease the likelihood of relapse within people while they're attempting to smoke. Varenicline decreases pleasure from receiving nicotine within the body. due to it acting as an antagonist on the nicotinic receptors. So, if a person is not deriving mental pleasure from smoking, they are less likely to continue to smoke. There's several different types of particulate matter that people can be exposed to. This is particles that's actually within the air. So, some of the things we have to look for is air pollution. This is going to be from gas combustion engines. This could be from plants that are pumping their waste products into the air. Older houses can have asbestos within the flooring or within the insulation and within the ceilings. Mold is also a problem within individual houses. And houses that were painted prior to the 1970s inside can have lead-based paint. And so if the paint breaks off, it can aerosolize. However, the larger problem with lead-based paint is children that are chewing on the windowsill and actually ingest that lead paint. Dust is composed of skin cells and it attracts other particulate matter and it sticks to the skin cells, so that can end up getting in the lungs as well. Sawdust is very refined and very small and is hard for the lungs to be able to clear once you're able to get it out of the body. So the cues that you need to recognize when you are doing a respiratory assessment. First thing is find out about the respiratory history. As we talked about earlier, be able to know how many pack years a person has been smoking. Look at other drug use. Are they taking other prescribed medications, or are they using inhalants? Some inhalants have created better high than others. Patients will frequently come in from huffing paint and have silver around their nares. And this is because the chemicals that make paint silver actually are reported to have a better high than other paint colors. Have to watch out for swelling within the airway with allergies. Also, asthma can be a problem here as well. Travel and geographic area of residence. So, if somebody has traveled to the West Coast, there's certain things within the air that can create infections, one of which is valley fever. That's not something we would be looking for, particularly in Tennessee. So, family history, we need to find out if there's other people in the family with allergies, asthma, cystic fibrosis, and find out what the patient's other comorbidities are. What other issues is the patient struggling with? So, our physical assessment, with our physical assessment, we need to look at within the nose, look for any kind of nasal polyps. Treatment for nasal polyps is going to be nasal corticosteroids. Look at the throat to be able to see the pharynx, the trachea, the openings, and the larynx. So it's also important to assess the lungs and the thorax. Listen for breath sounds. If a person is having difficulty breathing, it's often helpful to have them lean forward in a tripod position, put their lips together like they're going to whistle, and it's called pursed lip breathing. And it will help them to be able to empty the lungs out and be able to take in a deeper breath. Other things that need to be watched out for is hemoptysis. That's when there's blood within the sputum. People who are having difficulty breathing, if you can't breathe, you can't move. You can't move, you can't take care of yourself. So dyspnea, it often interferes with ADLs. When a person is having difficulty breathing in certain positions only, that's called orthopnea. And so a person who can't breathe while lying down on their back, supine, has orthopnea. When we're listening to the lungs and we hear fluid within the lungs, that is called crackles. We also can have air that develops under the skin, and this is called crepitus. When you are moving, it looks like just little bumps under the skin. It sounds like Rice Krispies, but it's within the skin, not within the lungs. Fremitus is a vibration of the chest wall that occurs when speaking. There's an increase of fremitus with pneumonia due to an increase of density of the secretions due to the infection. So, big things to remember is to review your breath sounds and know what a pleural friction rub sounds like and what that is from. A pleural friction rub often occurs in a condition called pleurisy. And during pleurisy, it's a very, very painful uh, condition to have. When a person takes a deep breath, it hurts. Now, this is separate from any kind of muscular pain. This is actually due to irritation within the pleura that's covering the lungs to protect the lungs. Here's a picture of the nose and sinuses, and big thing is to assess which sinuses that you're having problems with. I'm sure you've had this done at the doctor's office. You put pressure on that specific area using your finger and touch, and that determines if there's irritation. It shouldn't hurt with somebody pressing on your sinuses, but if there's infection, it very much does hurt. Here's what the pharynx, the trachea, and the larynx look like. So the pharynx opens up in the upper part of the back of the throat. Now, the larynx is the voice box, and when we are putting in advanced airways, such as an endotracheal tube, then you have to actually place the tube in between the vocal cords. By placing it in between the vocal cords, it allows you to be able to maintain an airway and ensure that the patient is able to breathe. Okay, so when we're listening for breath sounds, the sequence is always starting at the upper part of the back and listening left to right. So as you see the sequence, it's numbered so you can assess all the different aspects of the lungs and be able to figure out if there's any issues with the lungs. So, other indicators of making sure that respiration is adequate is looking at your patient's skin color. If a patient's respiration isn't adequate, first they will have some changes within the skin. The skin will get very pale, and then eventually it will get a gray hue to it, potentially a blue hue to it as well. Mucous membranes in people who are African American or darker skinned, it can be difficult to see this bluish hue. So other places where we could look to assess respiratory adequacy is going to be the conjunctiva with the eyes and also mucous membranes of the mouth. So, other ways we can tell if a person has been having long-term respiratory problems is looking at their fingernails. And if their fingernails, we call it clubbing, it looks like an upside down spoon. And so, if somebody has been experiencing long-term respiratory issues, and respiratory difficulties, low oxygen saturations, the fingernails will change and create a clubbing of the nail. So there's tons of pictures on this online. Difficulty breathing makes you work really hard to be able to breathe. So people who have true difficulty with breathing tend to be dropping weight. and there will be changes within the chest wall composition of the amount of muscle versus the amount of the ratio between the bone and how far the chest can expand with breathing. When a person is truly having difficulty breathing, they often will stop to take a breath while talking and while walking. It's very difficult for them to have the endurance that other people have within moving. So, when you can't breathe, it's a very scary feeling, creates anxiety. Often you're going to be losing your work roles, creating financial problems, unemployment, disability, and you need to talk to patients about how they're coping and talk to family members about how the patient is coping as well. Laboratory assessment, we want to look at the red blood cells. We want to look at ABGs, make sure we have an appropriate pH within the blood. Sputum specimens. So, sputum is when we have somebody coughing, they're coughing something up. This mucus is what's called sputum. So we'll give them a cup, and whenever they're coughing, we ask them to spit the sputum, the things that they cough up, into this cup, and we'll put it on a smear and see what grows on it. So, by finding out what type of bacteria is actually growing from the sputum, allows us to be able to tailor our antibiotic to more specifically address the specific agent that is causing the problems. So, imaging is going to be looking at chest x-rays or CAT scans. There's other non-invasive ways such as pulmonary oximetry. So, pulmonary oximetry, remember, treat your patient, not the monitor. In situations with such as carbon monoxide poisoning, your pulse oximetry can be completely normal. All that is looking at is the hemoglobin saturated. It's not assessing is it actual oxygen that's on the hemoglobin. In carbon monoxide poisoning, carbon monoxide binds with the hemoglobin tightly, more tightly than oxygen, so it doesn't actually get off and let the oxygen ride to the body like it needs to be. Sorry about that. So, when we are looking at more invasive studies, this is going to be bronchioscopy. It's going to be something that's done in IVR. We could also do a thoracentesis, and that will be done in the patient's room, having them lean over a bed table. And then lung biopsies, checking for cancer, will be done in IVR. Okay, thank you very much for watching. If you have any questions, let me know.